Yes, Dr. Aniket, we are live.
Yeah, you can start now.
Yeah, sure. So good afternoon, respected ma'am and my colleagues. I am Aniket Agarwal, a student of batch 2018 from Government Medical College, Jagdalpur, Chhattisgarh. I'll be presenting a seminar on the topic and structures of angle of anterior chamber. So here are the contents of my seminar topic. Sorry, ma'am. Hello.
And the whole 5 was supposed to be public awareness programs, isn't it?
Yes, ma'am. So, ma'am, this is a ma'am. In this, like the seminar, I'll be describing what are the structures in the what is the angle of anterior chamber. Firstly,
okay, continue. Okay, carry on.
Yeah, sure, ma'am. So these are the contents of my seminar. I'll be giving a brief of the eyeball. Then I'll tell about what is the anterior chamber, the angle of anterior chamber, how it develops, how the outflow of aqueous occurs from the posterior chamber to the anterior chamber, followed by the examination of angle of anterior chamber. So human eye, also known as the eyeball. Human eye is a globe, the walls of which consist of an outermost coat, a middle layer, and the innermost layer. The outermost layer is made up of elastic supporting tissue, mainly cornea, which forms the anterior 1/4, and the opaque sclera, which forms the remainder 3/4 of the eye. The anterior part of the sclera is covered by a mucous membrane, the conjunctiva. Inner to the sclera is the middle layer, composed primarily of choroids, which are present posteriorly, and the iris, which are present anteriorly. The retina forms the innermost layer of the posterior 2/3 of the 3/4 of the eye and lines the posterior part of the eye up to its ora serrata. The eyeball can be divided into two segments: the anterior chamber, the anterior segment, and the posterior segment, whereas the anterior segment can further be divided into an anterior chamber and a posterior chamber. The anterior chamber. The anterior chamber is an angular space. The anterior chamber, just a sec. The anterior chamber is an angular space bounded anteriorly by the back of cornea and posteriorly by the anterior surface of the iris, part of ciliary body and the pupillary aperture. The dimensions of anterior chamber. The anterior chamber is about 2.5 mm deep in the center. Young children and old people, as well as the myopic patients, have a very shallow anterior chamber. The volume of anterior chamber is 0.25 ml. Anterior chamber thus contains 0.25 ml of aqueous humor. Contents of anterior chamber: Schwalbe's line, a trabecular meshwork, scleral spur, the anteriormost part of the ciliary body, and the root of iris. So the angle of anterior chamber. The peripheral recess of the anterior chamber is known as the angle of anterior chamber and is bound posteriorly by the root of iris and the ciliary body and bound anteriorly by the sclera corneal. The angle of anterior chamber plays an important role in the drainage of aqueous and is formed by, again, the root of iris, anteriormost part of the ciliary body, scleral spur, trabecular meshwork, and the Schwalbe's line. The angle width varies in different individuals and plays a vital role in the pathomechanisms of different types of glaucomas. The two types of glaucomas based on the angle width are the open angle glaucoma and the closed angle glaucoma. The open angle glaucoma, wherein the main pathology is in the black block of the trabecular meshwork and all the angle structures are easily visible. The closed angle glaucoma, wherein the main pathology is in the aqueous outflow and generally all the angle structures are obscure or not visible clearly. Clinically, the angle structures can be visualized by gonioscopic examinations. Gonioscopic grading of the angle width. The gonioscopy gives a grading of the width of the angle of anterior chamber. On the basis of the gonioscopic grading, most commonly used grading is Schaeffer system. The grades include 4, 3, 2, 1, S, and 0. The grade 4 is characterized by an angle width of about 40 degrees, and the configuration is wide open, and the structures visible are as shown on the table. The grade 0 is characterized by an angle width of almost 0 degree. The configuration is said to be closed and no structures are visible in grade 0. The given is the structure showing the figure showing various structures seen in the angle of anterior chamber, which include the trabecular meshwork, the Schlemm's canal, the ciliary processes, and the iridocorneal angle and the anterior chamber. The development of angle of anterior chamber. By the 7th week, angle of mesenchymal cells from the neural crest cells to develop the trabecular meshwork. In posterior aspect, the iris is formed from advancing bilayered optic cup. The corneal endothelium meets the derivative of iris at 15th week to demarcate the angle. The angle deepening continues even after birth. The outflow of aqueous and its association with the anterior chamber angle. As you can see, the aqueous mainly is formed in the posterior chamber, and then it travels from the posterior chamber to the anterior chamber, and then it is drained out via the trabecular meshwork and the Schlemm's canal. Examination of angle of anterior chamber. Several tests are available for examination of angle of anterior chamber. However, the most commonly used are oblique flashlight test, Van Herrick's method, gonioscopy, anterior segment OCT, that is optical coherence tomography, and the ultrasound biomicroscopy. Let's discuss about what's oblique flashlight test. Oblique flashlight test. In this, the depth of anterior chamber is evaluated by following a beam of light on the temporal limbus parallel to the surface of iris. Results of oblique flashlight test are interpreted as normal or shallow anterior chamber. Normal or deep anterior chamber, the beam of light will pass directly, illuminating the opposite limbus or the nasal limbus. Shallow anterior chamber, that is characterized by bowing forward of iris, obstructing the light, and shadow is observed over the nasal half of the iris. This is characteristically known as eclipse sign seen in oblique flashlight test. Van Herrick's method. Van Herrick's method is a slit lamp examination of angle using oblique illumination. In Van Herrick's method, the peripheral anterior chamber defect is compared with the corneal thickness. The ratio of peripheral anterior chamber defect to corneal thickness, if the ratio is greater than or equal to 1, then the grade is given to be 4 and the angle is said to be widely open. Whereas if the ratio of peripheral anterior chamber defect by corneal thickness is less than 1/4, then the grade given is grade 1, and the remark given is very narrow angle, which is potentially occludable, leading to closed angle glaucoma. Gonioscopy. Clinically, the structures at anterior chamber angle can be visualized by gonioscopic examination. Gonioscopy principally works on the elimination of total internal reflection. Gonioscopy can be a direct gonioscopy or an indirect gonioscopy. Contents seen on gonioscopic examination. Contents seen on gonioscopic examination include ciliary body band, scleral spur, trabecular meshwork, and short baseline. Ciliary body band. Ciliary body band appears as a gray dark brown band consisting of longitudinal fibers. Contraction of the longitudinal muscles lead to opening of the trabecular meshwork. Scleral spur. The pale transparent narrow strip of scleral tissue is known as scleral spur, attached anteriorly to the trabecular meshwork and posteriorly to the ciliary muscles. Trabecular meshwork. Trabecular meshwork is a sieve-like structure made up of connective tissue lined by trabeculocytes. The main function of trabecular meshwork is drainage of aqueous humor. Meshwork is morphologically and functionally divided into 3 types: the uveal meshwork, the corneoscleral meshwork, and the juxtacanalicular meshwork. Schallway's line. Peripheral termination of Descemet's membrane. Schallway's line is the anterior-most structure of the angle of anterior chamber. ASOCT. ASOCT is the acronym for Anterior Segment Optical Coherence Test. ASOCT is a non-contact, non-invasive, light-based imaging modality. The working procedure of ASOCT is similar to ultrasound, which uses echoes to locate within the body. ASOCT provides higher image resolution compared to the UBM or the ultra-biomicroscopy of anterior segment in cross-section. Also, in ASOCT, 4 quadrants can be scanned at once. These 2 are the advantages of ASOCT over UBM, which I'll be discussing next. UBM or the ultrasound biomicroscopy. UBM is a close contact, non-invasive immersion technique performed with the patient supine. The supine positioning of the patient helps in falling back of the iris diaphragm, thus deepening the anterior chamber and opening the angle for better visualization. However, with UBM, only 1 quadrant can be visualized at a time, which is a disadvantage over compared to airsucity. Also, there is a risk of infection or corneal abrasion in UVM due to contact nature of the examination. Thank you.
Hello.
Yes, ma'am.
So,
hello.
What do you think, which is in your clinical practice, which method of anterior chamber assessment of the anterior angle of the anterior chamber you would use?
Ma'am, mainly the gonioscopy examination. Gonioscopy examination is used, and the oblique flashlight tests are used. Ma'am, as these are outpatient procedures, so they can be done immediately, and they can give a differential for what is the pathology or the anterior chamber angle.
What about the plateau iris? Which group it will come to?
Sure, ma'am. Ma'am, the plateau iris configuration is comes under the angle closure glaucoma cases, where in the plateau iris is categorized by the forward positioning of the iris, leading to narrow angle closure, narrow angle of anterior chamber.
Okay, we can go to the next one. Nikita.
Hello.
Nikita.
Hello.
Yeah.
Am I audible? I'm Dr. Shuli Kumar. Actually, I was also nominated as a judge. Can I ask one or two questions?
Yeah, definitely.
Dr. Aniket. Okay. Aniket.
Yeah, yes,
hello.
Sorry,
can you listen to me? Good afternoon.
Yeah.
What is the gold standard of measuring intraocular tension?
Ma'am, intraocular pressure gold standard. Just a sec. Ma'am.
You told me, no? What is tonometer?
Yes. Goldman. Yes, ma'am. Perkins Goldman.
Yeah.
What is the name? Yes, Goldman tonometer. Yes. What are the other methods of measuring intraocular pressure?
Ma'am, other methods of measuring intraocular pressure, ma'am, Short's tonometer can be used. Short's tonometer can be used.
What is the principle of Short's tonometer? What is the principle?
Just principle of Short's tonometer. Skipping it. I'm skipping it. Sorry, ma'am, I'm not.
Okay. Okay. That's I wanted to know. And next one, you can proceed. Next one. Okay.
Next one is
next?
Nikita.
Okay. Nikita, you can proceed.
Yes, ma'am. Good afternoon, everyone. This is Nikita Vyas from Bharati Vidyapit Medical College and Hospital, Sangli. I am here to representing ophthalmia and neonatrum. So the introduction is the ophthalmia neonatrum, also known as the neonatal conjunctivitis. The definition, it is defined as a mucoid, mucopurulent or the purulent discharge from one or both the eye in the first month of the life, less than 28 days. The most common infection in neonate. So epidemiology, it represents a public health problem. Percentage of developing neonatal conjunctivitis is 2 to 12%.
Hello,
the
Nikita?
risk factor which are more common.
Hello?
Yes, ma'am.
We can't see your slides. Your slides are not visible.
Okay, wait, ma'am.
Can you stop sharing first? Get your presentation open, then start sharing, please.
Okay, sir. Okay, sir. Stop sharing.
First, open your presentation, then do the screen sharing, please.
So is it visible now?
Yeah, it is visible now.
Yes, 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 yes.
Okay. 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 Sorry, ma'am, for the inconvenience. Ma'am, this is Nikita Vyas from Bharati Vidyapeeth Medical College and Hospital, Sangli. I'm here to explain the topic ophthalmia neonatal. So the introduction is ophthalmic neonatal, also known as the neonatal conjunctivitis. It is defined as a mucoid, mucopurulent or the purulent discharge from one or both eye in the first month of the life, less than 28 days. It is most common infection in neonates. So the epidemiology, it represents a public health problem. The percentage of developing neonatal conjunctivitis is 2 to 12%. The risk factors are organisms in a birth canal, premature rupture of membrane,
Hello,
Yes,
Nikita.
we
Are
can't
you?
hear you.
We can't hear you. Oh, she's not audible.
Yeah, and her slides are also not moving.
Hmm.
hello.
Yes.
Nikita, are you there?
Yes, ma'am, I'm here.
Oh, so there is some problem in connectivity.
Hmm.
Yeah, now that's fine. Now we can
Yes,
see
ma'am.
your slides.
Okay, ma'am. Now, can I continue from the causative organism?
Yeah.
Okay, ma'am. The causative organisms are Neisseria gonorrhoeae, Chlamydia trachomatis, and the other bacteria are gram-positive and the gram-negative. The gram-positive are the Staphylococcus aureus, Streptococcus pneumoniae, Streptococcus viridian. Gram-negative are E. coli, Klebsiella pneumoniae, and the Proteus. So this is a picture which is showing the swelling and the purulent discharge, which are a characteristic of the gonococcal infection. So the incubation period of the gonococcal conjunctivitis are 3 to 5 days. Chlamydia conjunctivitis 5 to 14 days. Staphylococcus aureus 2 to 5 days. Streptococcus pneumonia, Haemophilus, and the Enterococci 2 days, and the Pseudomonas 5 to 18 days. The history, it can be occurred because of the installation of prophylactic chemical preparation, parenteral symptoms of sexually transmitted infection, recent conjunctivitis in close contact, systemic illness such as pneumonitis, rhinitis, otitis, in chlamydial infection, skin vesicles, and the features of the encephalitis in herpes simplex. The prior persistent watering without inflammation may indicate an uncanalized nasolacrimal duct. So the sign and the symptoms are pain and the tenderness, conjunctival discharge. It can be purulent or the mucoid. The lids are swollen. Conjunctiva, these are hyperemia and the chemosis. Rarely there is a corneal involvement, but if there is involvement, it causes the punctate keratitis in the herpes simplex virus, and the corneal ulcer occurred because of the pseudomonas infection. The differential diagnosis are necrocystitis, nasolacrimal duct obstruction, congenital glaucoma, keratitis, and cellulitis. This is the different type of the organism causing a conjunctivitis. So the differential diagnosis based on the timing of onset after the birth. They have the Neisseria gonorrhoeae within the first 48 hours, and the chemical conjunctivitis also occur within the first 48 hours. Then other bacteria such as Staphylococcus, Streptococcus, it occurs between 48 to 72 hours. Herpes simplex virus 5 to 7 days, and the Chlamydia trachomatis more than 1 week. This is the picture which is showing the different signs and the symptoms occurred because of the chlamydia. The investigation occur the gram and the germ cell stain, culture, bacterial culture, papillomavirus smear, nucleic acid amplification testing, viral culture, and the immunofluorescent testing. Prophylaxis will give the single instillation of iodine 2.5%, erythromycin 5%, and tetracycline 1%. Any suspicious vaginal discharge should be treated. Meticulous obstetric asepsis maintenance at birth. Newborns, babies' closed eyelids should be thoroughly cleansed. If mother infected with gonococcus and the chlamydia, then 1% tetracycline in the erythromycin eye ointment is given. Silver nitrate 1% solution. It was given earlier, but now it is not used. Then treatment, if there is a chemical conjunctivitis, will give an artificial TM. The mild conjunctivitis will give topical antibiotic, chloramphenicol and fusidic acid. Then the moderate to the severe cases, if bacterial evidence on the gram stain, then we'll give topical antibiotic. If there is a chlamydia infection, we'll give oral erythromycin. Then in severe conjunctivitis, if there is a gonococcal conjunctivitis, we will give third generation cephalosporin, and in herpes simplex viral, we'll give IV cyclovir. So this is the picture which is showing the affected eye in a herpes simplex virus, and the eye treated after 1 week. Then prevention in the program will screen all the pregnant women for gonorrhea and the chlamydia infection, treatment and follow-up of those found to be infected. Various program has been launched for the mother and the child health. These are National Health Program for Control of Blindness, Vision 2020, the Right to Sight, Janni Shishu Suraksha Karyakram, Child Health Program under NHM, the Women and the Child Health Program, and the National STD Control Program. Thank you.
Okay. So, is it still very common, ophthalmia neonatum?
Ma'am, as there is a ma'am, it is not so common in the developed countries, but in underdeveloped country, it is very common. It is very common, as Neisseria gonorrhoeae can it has the ability to penetrate the corneal epithelium, so it is the most common which is occurring.
Is there a difference between socioeconomic groups, incidence of this disease? Is there any correlation between the incidence of the disease and the socioeconomic status of the population?
Yes, ma'am. The people who are at a low socioeconomic status, they are more exposed to this disease because they have a Neisseria gonorrhoeae, because they have a more sexual contact with the multiple partners. So these are affecting more in a low socioeconomic status people.
Nikita, hello. Hello.
Yes, ma'am.
Which is the
Yes,
most
ma'am.
common organism responsible for this ophthalmia neonatum? Most common.
Ma'am, Neisseria gonorrhoeae.
Is that Neisseria gonorrhoeae, or what
Yes,
are the other first, second organism? What is the most common? Chlamydia. Chlamydia? What?
Ma'am, Neisseria gonorrhoeae and the chlamydia. Yes, ma'am. Chlamydia.
Okay. So if a child was found to be a nasolacrimal duct obstruction or the canalicular obstruction, how to proceed with that type of child? You said na in one of your slides. Yeah. Suppose the patient is having some.
In the nasal. Yes, ma'am.
Any idea? A child is having a nasolacrimal duct obstruction. A child, in one of you go through your slides. In the previous slides, you have said that the child can have a simultaneous obstruction in the nasolacrimal ducts. You said that, no?
Yes, ma'am.
So what to do in that case? Congenital NLD obstruction.
In congenital ma'am, we'll give the povidone iodine, and we'll give do the probe methods and the balloon catheter method. We'll give the massage and the probing.
Massage.
We will go step by step.
Yes,
step by step. Which step will be first? Which step will be first?
Ma'am, first we will give the massage.
Massage.
So,
yes.
First we'll give the massage. Then we will give the
How
probing.
long you will give the massage?
What will be the
Ma'am,
direction of the
till
massage?
the
Yes. Say. Hello,
yes, ma'am.
Nikita. Yeah.
Ma'am,
Continue.
till yes, ma'am. Ma'am, till the that the till we see that that there is any watery discharges is coming out from the nose, and we'll see.
Then you have to continue to do it till the child is 1 year old.
The age is very important. After that, you will do the other maneuvers. What are
Yeah,
the
then you do. Yeah.
probing? All this comes after, no? Okay, okay. Okay, that much I want to know.
Can we call? Sorry, can we call Rashi?
There's so many noises.
Background
Lots of
noise
noise.
is coming. Please mute yourself. Hello? There's a lot of noise. Please mute yourself. Surely, can we call Dr. Rashi?
Hall 6, no?
Yes. Yeah.
Yes, hall 5.
Rashi Goel is there?
Yes, ma'am.
আর একটাই বাকি থাকলো hall 4 গুলো।
Start your presentation.
Yes, শিউলি কুমারী back হচ্ছে।
Good afternoon, Dr. Samanto.
Good afternoon. Good afternoon. So, how many candidates are there in this? May I just have a roll call in hall 5? Ankit Agarwal is here.
Yeah, already presented.
Already presented. Good. Then, yes.
And Nikita also presented.
Nikita Bas. Nikita Bas.
Nikita was from.
Nikita Bas from Sangli. Presented.
Yes, presented. Yeah.
Thank you. And Miss Rasanti from Salem.
No, we are waiting for Rashi.
Rasi from Salem.
Yeah, she has to present.
Okay, that's nice. Good. And Dr. Rashi Goel from Ghaziabad. Okay.
Yes.
Rashi Goel is there. And Dr. Arindam Hasda from Medical College, Kolkata.
I don't think they are there.
Arindam Hasda is not there.
Yeah, only these 3 participants are there.
Oh, okay, that's nice. Good. So carry on and find out the best one. Okay. Thank you very much. Carry on. Okay.
Rashi, you can start.
Thank you very much, Professor Kumudini Sharma. After a long time, I can find you. And along with me here, Professor Dr. Chandra Chakraborty is there. And Dr. Shivli Kumar is also from Calcutta National Medical College.
Yes, thank you, sir.
Thank you very much. Thank you. Carry on.
Thank you,
Carry
sir.
on.
Welcome, sir.
Great time. Okay. 5.
So you can start, Rashi.
Yes.
Good afternoon, respected judges, committee members, and all my fellow mates present here. Today, I, Rashi Goel from Santosh Medical College, batch 2018-19. I'm going to present a topic, National Program for Control of Blindness, Vision 2020, and its achievements. Vision 2020, just right to sight, it is a global initiative to eliminate avoidable blindness, was launched by WHO on 18 February 1999. One significant way in which this initiative differs from previous ones is that the concept centers around rights issues. Objectives includes to review the current status of blindness and visual impairment and progress in implementation of country activities in member countries, to orient the participants on global initiative for elimination of avoidable blindness, Vision 2020, the right to sight, to formulate a regional strategy and plan of action for Vision 2020 and to develop a template for designing or redesigning national plans of action to meet the objectives of Vision 2020 and work out a time frame for national launches of Vision 2020. Program organization and implementation includes the primary level, sub-district level, hospitals, community health centers, mobile ophthalmic units, primary health centers, and panchayats. At secondary level, we have district hospitals, NGOs, eye hospitals. At tertiary level, we have Regional Institute of Ophthalmology, centers of excellence in eye care, and medical colleges. Aims include strengthen advocacy at all levels, reduction of disease burden, strengthen physical infrastructure and human resources, management information system for better program management, transparency, and coordination. Strengthening advocacy at national and state level includes public awareness and information about eye care and prevention of blindness, introduction of topics on eye care in school curriculum, involvement of professional organizations. At district level, we have to enhance involvement of NGOs, local communities, societies, and community leaders to, to strengthen hospital retrieval programs for eye donation through effective grief counseling by involving volunteers. Reduction of disease burden. The target diseases identified for intervention under Vision 2020 initiative in India include cataract, childhood blindness, refractive errors and low vision, corneal blindness, diabetic retinopathy, glaucoma, and trachoma. Disease control programs. Cataract includes intensified surgical intervention, gap caps at all district levels. Childhood blindness includes schools eye screening program, vitamin A prophylaxis, refractive errors and vision and low vision, refraction centers in all primary health centers by 2020, low vision service centers in all tertiary care center, corneal blindness, eye banking, glaucoma, opportunistic screening of eye care institutions, eye camps, diabetic retinopathy, awareness generation by health workers, laser treatment, and at tertiary level, trachoma safe strategy. Now talking about cataract, cataract continues to be the single largest cause of blindness. According to latest national survey in India 1999 to 2001, 62.6% of blindness in 50 plus population of India was found to be cataract related. Objective was to improve the quality and quantity of cataract surgery. Target as per Vision 2020 include targets for cataract surgery rate, fixed intervention 2020 strategy were 6,000 by 2020, intraocular lens surgery for more than 80% by the year 2005, and for all by the year 2010, YAC capsulotomy services at all district hospitals by 2010. Strategic activities to clear backlog of cataract include primary screening by community health worker to identify persons with visual impairment, finger counting less than 6 meters in any eye, case selections by eye surgeons at screening camps and at base level district hospital. Granted aid for cataract surgery may continue to be released through District Blindness Control Society. Now talking about childhood blindness. Childhood blindness is an important public health program in developing countries due to its social and economic implications, extent and causes of problem. Prevalence in India is 0.8 per 1,000 children by using correlation between under 5 mortality rate and prevalence. Common causes of childhood blindness includes vitamin A deficiency, measles, conjunctivitis, ophthalmia neonatal, injuries, congenital cataract, retinopathy of prematurity, and childhood glaucoma. Refractive errors are the commonest cause of visual impairment in children. Aim is to eliminate avoidable causes of childhood blindness by the year 2020. Strategies and activities under Vision 2020 includes detection of eye disorders at the time of primary immunization, at school entry, periodic checkup every 3 years for normal and every year for those with defects, preventable childhood blindness to be taken care of through cost-effective measures. Prevention of xerophthalmia is of utmost value in preventing childhood blindness. Prevention and early treatment of trachoma by active intervention. Refractive errors to be corrected at primary eye care centers. Childhood glaucoma should be treated promptly. Prevention of premature retinopathy of prematurity by proper screening and monitoring. Use of oxygen in premature newborns. Curable childhood blindness due to cataract, retinopathy of prematurity, corneal opacity, and other causes to be taken care of by the experts at secondary and tertiary eye care services. Targets include establishment of refraction services and low vision centers, establishment of pediatric ophthalmological units. Now talking about the refractive errors and low vision, according to rapid assessment of avoidable blindness conducted in 2006 and 2007, refractive errors including uncorrected aphasia were responsible for 6.3% of blindness and 35.6% moderate to severe vision impairment. Targets include availability of low cost, good quality spectacles for children to be insured, Low vision service centers are to be established at 150 tertiary level eye care institutions. Now coming to glaucoma. As per the National Survey on Blindness 1999 to 2012, the Government of India Report 2002, glaucoma is responsible for 5.8% cases of blindness in 50 plus population. Opportunistic glaucoma screening, case detection by tonometry and fundus examination recommended is as follows. Opportunistic screening at eye care institutions should be done in all persons above the age of 35 years, those with diabetes mellitus, and those with family history of glaucoma. Community-based referral by multi-purpose workers of all persons with diminution of vision, colored halos, rapid change of glasses, ocular pain, and family history of glaucoma. Opportunistic screening at eye camps in all patients above the age of 35 years. Now, talking about diabetic retinopathy is emerging as an important cause out of 4.7% cases of blindness due to posterior segment disorders in 50 plus population. National Survey 1999 to 2001. Following recommendations are made: awareness generation by health workers, confirmation by fundus fluorescein angiography, and treatment of diabetic retinopathy at tertiary level, including laser treatment. The strategy must be to bring down the medical management of diabetic retinopathy at the secondary level. Now, talking about corneal blindness, objective to reduce prevalence of preventable and curable corneal blindness. Strategies for control of corneal blindness are: first, general strategies include identification of infants, preschool children, school children, senior citizens with post-cataract surgery. Disease-specific strategies are as below: eye infections including ophthalmia neonatum, ocular prophylaxis at birth with broad-spectrum antibiotics is very important. Eye surgery, eye injuries, education of people regarding avoidance of ocular trauma like cracker bursts, industrial accidents, road accidents, and other trauma, thereby reducing irreversible corneal blindness. Trachoma blindness. In India, the corneal blindness due to trachoma is one on the decline. Prevention of xerophthalmia, vitamin E supplementation program. Keratoplasty and eye banking. Under National Program for Control of Blindness, eye donation fortnight is organized from 25th August to 8th September every year to prompt eye donation. Under Vision 2020, Indian initiative emphasis is on hospital retrieval system to get better donor material. Human resource development. Mid-level ophthalmic personnel include all categories of paramedics who work full-time in eye care. Broadly, two streams of such personnel are envisaged. First is hospital-based mid-level ophthalmic personnel, which include ophthalmic nurses, technicians, optometrists, and orthoptists. And at community-based mid-level ophthalmic personnel, we have primary eye care workers and ophthalmic assistants. Infrastructure includes at primary level, we have vision centers. At secondary level, we have service centers. And at tertiary level, we have Center of Excellence and Training Centers. At vision centers, we have refraction and glasses prescription, primary eye care, school eye screening programs, screening and referral services. At service centers, we have cataract surgery, other common eye surgeries, facilities for refraction and referral services. And at tertiary level, at training centers, we have tertiary eye care and training and CME. And at Center of Excellence, we have professional leadership, strategy development and CME, laying standards, quality assurance, and research. Now talking about the achievements, thanks to Vision 2020 advocacy, all 193 WHO member states are formally committed to investing in eye care. Two World Health Assembly resolutions have urged WHO member states to develop and implement Vision 2020 national plans and WHO to provide technical assistance. A WHO action plan for prevention of blindness and visual impairment has now been prepared and was unanimously adopted at the 2009 World Health Assembly. 135 countries have participated in a Vision 2020 workshop. 107 countries have formed National Vision 2020 committees. 91 countries have drafted national eye care plans. To date, 15 million fewer people are blind compared with projections made when the initiative was launched. Thank you.
बस last. Hello.
Hello.
Darshik, what about why they have not included the traumatic eye injury in this, which is also a preventable blindness.
কোড কিসে আচ্ছা মেসেজে
Traumatic eye injuries are included in
কোথায় আসবে আচ্ছা, আসেনি তো এখনো হ্যাঁ 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 আরেকবার পাঠাতে বল
And which is the important program, which is the important, like a very prominent disease for under which lot of ophthalmic societies are working for, and they are having their public awareness program, and which is the commonest disease now. Cataract is not that common now. Most of the backlog has been covered, yeah. But which is the disease now? A lot of ophthalmic societies are talking about and having public lectures for awareness.
diabetic retinopathy.
Yeah, that's true. And
hello yes
yeah,
ma'am
okay,
continue
yeah.
hello Rashi the first thing I want to say that you have used very small font sizes so it's very difficult to see na try to use bigger font size and okay and what is the full form of NPCV
National Program for Control of Blindness.
and what is the your concept for eye banking do you know
Eye banking, yes, ma'am.
Yeah.
Ma'am, it is an organization where we select and we assess the donors, and we periodically check the persons who want to donate. Their periodic checking is done, and for preservation of the eyes which are donated, and creating awareness about eye donation.
Can you name some media where the donated eyes are stored?
There are long-term and short-term media.
Mm-hmm. Name some medias.
Doctor, please close your presentation.
Okay, okay. Ma'am, liquid nitrogen can be used.
Okay.
Anybody else who's sharing? Hello. Hello.
Hello. Can anyone listen to me?
Yes, ma'am, we can listen.
Is that over?
If the presentations are over, we can close.
Actually, I don't know what who are left.
Ma'am, if you can see the participants, you can see the names.
So whoever is the next, kindly present.
I think we've done with the presentation.
Okay. That's so it ends the
No.
meeting, na?
Okay. You want me to close it now?
I don't know. Should I leave?
Yeah, but Dr. Aniket, Dr. Nikita, Dr. Rashik. Everybody's done the presentation. Anybody pending with the presentation? Anybody left with present? Please speak up.
No, sir. No, sir. No, sir.
No
I think
one
we are
is
done, ma'am.
present. Yes. Okay.
So should I close?
Sir, where will we get the result
Okay.
of first round? Hello.
So I'm closing, ma'am.